Good afternoon, ladies and gentlemen. My name is Ashley Ewing, Event and Conference Manager at the Virginia Hospital and Healthcare Association. On behalf of the association, I would like to welcome you to the statewide webinar on the opioid addiction crisis. A few housekeeping items to take care of before we begin. Please make sure your phone is on mute, as well as your computer mic. Avoid placing your phone on hold, as it may become a distraction to other listeners. This webinar will be recorded. The slides and link to the recording will be sent to you within 1 to 3 business days. If you experience any technical difficulties during this webinar, we do have a GoToWebinar assistant with us today. Her name is Tony Funk, and she is available via the question feature at the bottom of your control panel. Due to the volume of participants on this webinar, there may be a slight delay when transitioning slides. We will be holding questions until the end of all presentations. At the conclusion of the presentations, please type your questions into the question box. We have allotted ample time for the question and answer session. We will not be accepting questions via the phone due to the large amount of participants on this webinar. We hope you enjoyed today's session. I will now turn the webinar over to my colleague, Carter Lyons, to introduce today's presenters.
Good afternoon, everyone. My name is Carter Lyons. I am the Director of Education for the Virginia Hospital and Healthcare Association. We are so very glad to have you with us. Thank you for making time in your day to take part in this session. The level of interest in this session speaks to the enormity of the problem. There are more than 600 on this call today, and you bring with you a wide variety of professions, backgrounds, and roles within your communities. Each of you truly can make a difference, and your impact can be far-reaching. Our presenters not only have a tremendous amount of expertise in this area, but they are deeply committed to confronting this challenge and have made great progress. So allow me to introduce to you these amazing folks. We are privileged to be joined today by the Honorable William Hazel, Secretary of Health and Human Services for the Commonwealth of Virginia, who set forth this challenge for our state. Secretary Hazel, thank you for joining us today.
Thank you, Carter. I appreciate VHHA taking on this webinar, and I appreciate our friends at the Northern Shenandoah Valley for their community efforts to address this crisis. Clearly, when you have a problem where more people are dying from opiates and combinations of opiates and benzodiazepines than from motor vehicle accidents, we have had a major shift in the need to address priorities. And as we have worked at the state level, recognizing the issues through the Task Force on Prescription Drug and Heroin Abuse and so forth, we've recognized that all of there are things that the state can do, and I will address some of those. The solution will really have to involve local activities, local culture change, which will only come about with groups working more closely together than they ever have, if they ever have. And the efforts in the Northern Shenandoah Valley around Winchester, Clark County, the hospitals, Valley Health, the CSBs, the prosecutors there to actually work together in a regional coalition to address the problem, I think is a model that we can all learn from, and I'm very thankful that the Hospital Association, the Hospital and Healthcare Association, has been willing to help us learn how this was done and how we can do this around the Commonwealth. I will mention a few things that have happened at the state level legislatively. One thing that has been very useful over the last year and a half has been expanded use of naloxone. And I know recently the Virginia Beach Police Force has had 2 saves from naloxone, which would have been deaths previously. So these efforts have helped. We have programmatic initiatives around the prescription drug monitoring system, and I think Ralph Orr will discuss these more later in the program. It's important that this tool be used by the medical community, the pharmacy community, to help avoid prescribing where perhaps the prescriptions have been misused. we at the state level have created a health and criminal justice data committee, and through that we will share opiate-related data across agencies from health, the medical examiner, the hospitals, law enforcement, the state police, all are sharing to help us understand this epidemic. We have been working with our neighboring states. We had a summit in Wise last fall where we invited our colleagues from North Carolina, Tennessee, West Virginia, Kentucky, and Maryland to a meeting. We had a follow-up meeting in Atlanta last month, and participants generally felt that what we had shared is incredibly important to them. This epidemic does not respect geopolitical boundaries whatsoever. Another area that we think will be very helpful, Medicaid has been authorized to create a substance use disorder treatment waiver for Medicaid patients. That is, we're working on that now, and that will be implemented as soon as we can get that up and running, provides hopefully some resources for treatment of individuals who are suffering from addiction. Clearly, there's more out there. The CDC guidelines, prescribing guidelines are in place. The Board of Medicine has been authorized to create some medical education requirements for providers that prescribe significant amounts of opiates. Reporting times have been tightened up so that the dispenser's reporting will now be 24 hours as opposed to 7 days previously. And we will be able to generate reports that will help you know when egregious dispensing behavior has occurred. So all in all, there's a lot at the state level, but the long and short of it is that we have to address this issue of the culture of using prescription drugs freely. They aren't safe because they are prescription. We have to continue to treat the individuals who are suffering from addiction. We need to look at the peer engagement. We have to address neonatal abstinence syndrome, and we have to address this flow of heroin. And I think that our friends in the Northern Valley have a lot to share with us that will be useful. So with that, Carter, I will turn it back over to you, and I thank you for the opportunity to introduce this conference.
For that background information, for those updates, and for stimulating this important conversation. Up next, we will hear from 3 presenters who are part of a community organization that has made great strides in this battle. Nick Restrepo is the VP of Medical Affairs at Winchester Medical Center. Kevin Sanzenbacher is the Chief of the Winchester Police Department, and Tim Coyne is a public defender. You will soon see that they need very little introduction. Their knowledge will speak for itself. Gentlemen, the floor is yours.
Thank you. I'd like to, this is Nick Restrepo. I'd like to start off by thanking everybody at the VHHA, Ashley, Carter, and Abraham for getting this all together, and particularly Secretary Hazel for his dedication to this issue and commitment to helping guide the Commonwealth as we meet this most difficult challenge. On the second slide, what we'll do is kind of give you a little bit of an overview of the presentation. And what we've done is weave together in somewhat of a chronological order our community history over the past couple of years and how we got to where we are today. We will highlight some of the Valley Health initiatives as well. As the next slide says, the story that we want to share is a story of a coalition that's been built, and it's a dynamic, multidisciplinary collaboration between law enforcement, where you have both prosecution and defense resources together, health and child welfare, family courts. We have county and city leadership and different community members, all of which collectively we're working together to address the crisis of heroin and opiate addiction. We've been blessed to have help from the Casey Family Programs, from Joan Ohl and all the resources of Casey Family Programs who have worked with the state before, but at this point are working with us on a local level, and that's been a very fortunate occurrence for us that has helped us help guide our initiatives and help keep us on track. We've brought together a diverse group of partners and work collaboratively across all these disciplines to begin to respond to a public health crisis that is impacting the Valley, the Commonwealth, and the entire country. We realize we're just at the start of this, but we're going to share the story of where we've been and where we are and hopefully where we're heading. I'll now have Kevin Sanzenbacher take us through our community reality, which starts with the next slide.
Good afternoon. It's my job to kind of let you know how we got to where we're at. And I'm sure as in most your community, our major drug activity here in the valley is enforced by a regional drug task force. And that task force at the policy level is run by a command board, which is all the sheriffs and chiefs in the area. And we meet regularly. Well, in the beginning of 2013, at one of our regular meetings, our state police coordinator came forward and said they're starting to see a lot of unusual activity related to heroin, which we hadn't seen for a number of years. That included increased arrests, increased seizures, and unfortunately increased deaths. For example, in 2012, we had 1 death, and by the end of 2013, we're up to 21. We'll have a slide to show that progression here in a minute. We came to a realization very quickly that we were not going to be able to arrest our way out of this situation, that it was far more than a law enforcement issue. It really was a community health issue. So we decided at that point to reach out to many of our partners within the area and see if we could hold a couple of information seminars to kind of alert both our healthcare providers, the other members of the legal profession and criminal justice for treatment, and service providers of the issues that we were starting to see being formulated and what were showing up on our screen. And we really decided that we were going to approach it as a three-legged stool. And that would be, one leg would be the enforcement aspect that we would take care of, and then we were also looking at prevention and treatment. As a result of that activity, we called for a number of seminars that were held that year and have kind of led to the activity we're going to talk about in more detail now. As I said, we noticed a significant increase. If you look at the chart here that's available, from 2012, we had 1 death related to heroin, and by 2013, we were up to 21. And that progression continued, 33 in 2014, 30 in 2015, and we currently have 6 to date in 2016. That is a trend that is down a little bit, and we associate that trend with an increased availability of naloxone. Our local sheriff's department, for example, is started issuing naloxone to his deputies, and they are administering it in overdoses, and they've had 2 saves already since February of this year.
The next slide is a slide that shows 2 different data points that are complementary. On the top side portion of the slide, what you see is a change in population of various areas, all the way to the right being the Commonwealth of Virginia. Between 2010 and 2013, increased by 3.2%. Fairfax County by 3.3%, Loudoun County by 12%, and the Clark, Winchester, Frederick area by 3.7%. On the lower set of bar graphs, what you see is the change in heroin and opioid deaths during that same time period. So you can see that the entire state has been adversely impacted, with the Commonwealth going up 42.8% that time, Loudoun being up 87.5%. Our area has had a 175% increase. And so despite having a local population growth that was similar to Fairfax, similar to the Commonwealth, we had a significantly higher impact with regards to mortality from heroin and opioid during that same time period. The next slide, Tim Coyne will take you through, and Tim's our public defender.
Good afternoon. I am the public defender for the city of Winchester and surrounding counties in the northern Shenandoah Valley. That includes Clark, Frederick, Shenandoah, Page, and Warren. So we cover a large area in the northern part of Virginia. As the chief mentioned earlier, we started experiencing a tremendous increase in the number of deaths. I started to see that in my caseload with clients dying, but also an increase in the number of possession and distribution cases involving drugs in general, but heroin in particular. And along with that, we've also seen an increase in other crimes. This chart shows on the far left the increase in drug and narcotic offenses. This is data maintained by the Virginia State Police for Winchester, Frederick, and Clark. You can see the upward trend from 2012 to 13 to 14. Along with that, also, we saw a significant increase in larceny offenses that are related at their core by drug abuse. We have a number of clients who go into retail stores, shoplift a number of items to go and pawn them and sell them in places like Baltimore so that they can get money for drugs. We also have a high degree of assault cases that again are attributed to substance abuse and drug abuse at their core. To a lower extent, you see fraud, embezzlement, burglary crimes as well. So it has a wide effect across the spectrum, affecting not just the criminal justice system, but as you'll see on the next slide, our jail population as well. The Northwest Regional Adult Detention Center serves Winchester, Clark, Frederick, and also inmates from Fauquier County. And they have an excellent program there called the ORTP program. That's the Offender Reentry Treatment Program. It's a 90-day program. Initially, it was started out to facilitate inmates leaving jail going into the community. But by necessity, it's become, in effect, our default substance abuse treatment program within the criminal justice system. And so from statistics we've gathered from July of 2011 through the end of last month, over 1,200 inmates actually participated in that program. 724 of them graduated. The difference is there were inmates released, inmates transferred to the Department of Corrections, and some, a lesser number, dropped out. But the cost for that treatment, calculating 90 days at $81 a day, comes out to over $5.2 million that the local governments, Winchester, Frederick, and Clark, have had to expend providing some element of treatment, substance abuse treatment services for inmates that are in our local jail.
The next slide, what we'll see is the impact that we saw at Winchester Medical Center. I think it's important to realize that these numbers are patients with primary diagnosis of opiate or heroin overdose and not those with comorbid conditions. And in 2012, we were starting what has become a relatively robust patient safety program in Valley Health's journey to high reliability. And in that part of that patient safety program was the initiation of a daily safety call where we, 7 days a week, have a briefing from each one of the unit's charge nurses, looking back over the past, since the previous safety call, looking forward to the next, and following up on prior issues. And I have the opportunity and really the fortune of being the primary host of that call on weekdays. And what I noticed as we launched that call in 2012 is that I'd lived in this community at that point for 17 years and practiced as a urologist for 15 years. And it wasn't until that call started that it really impacted me, the tremendous adverse effect that addiction was having on our community. I would hear it on every call, whether it be newborn babies withdrawing from their substance exposure, or whether it would be adult patients withdrawing and the impact on them, their families, and our caregivers. And it is very adversely impactful on the caregivers if you don't have a proper setting for the patients. And it really struck home. And at the same time, we saw this increase, as Kevin mentioned earlier, around the mortality that we were seeing in the community. This is a part of what helped move myself and us towards engaging with Kevin and others to try to address this. Tim will show us on the next couple slides some of the impact on the social service of our area.
Right. We also started seeing, in this chart, this particular chart shows just figures for the city of Winchester. This is data from the Winchester Department of Social Services. And what it's showing you is the increase in the number of children who have actually been removed from their homes based on allegations of abuse and neglect by their parents or caregivers and placed into foster care. Back in 2012, the numbers were fairly low. Our Juvenile and Domestic Relations District Court, led by Elizabeth Kellis, who's a member of our coalition, prior to that had taken great pains and efforts to try to reduce the number of kids in foster care by providing services to the families before you get to the removal. And in 2012, there were a total of 22 children in foster care in the city of Winchester, 5 that were attributable to the substance abuse of their parents or caregivers. And as you can see, that number steadily increased from 2012 up through 2015 to the point where we now have 56 kids at the end of 2015 in foster care. 42 were directly related to the substance abuse of their parents or caregiver. And this would not include cases where the Department of Social Services was working with families on either a safety plan or providing services where the children did not actually have to be removed from their home. Next slide, please. We'll show the impact of substance-exposed infants reports to Child Protective Services. And this graph shows numbers from both Frederick County and the city of Winchester. For those of you that don't know, the Winchester Medical Center is physically located in the city of Winchester, but serves a large geographic population. And so they take these reports based on the residence of the mother. They climb in both the city and Frederick over the total time of 2010 to 2015, we did see a slight drop in Frederick County numbers reported from 2014 to 2015, while the city numbers have continued to go up.
On the next slide, we represent the impact to the newborn babies in our hospital. And you can see during the time period noted, hand side, roughly 6,500 children were born with an average length of stay of 2 days and a couple $1,000s in cost. At that point, we were helping children withdraw in two different arenas. One was in the newborn nursery using a methadone and morphine protocol, and then the other was for the more severely affected children. Their length of stay significantly increases. You can see it's 8.5 days and just about $7,500 the total cost for the, I guess one would say, less affected children, and 22.1 days for the children going to the NICU was the average length of stay with a cost over $40,000 per child. As the next slide says, this led the community to respond. And continuing on, what we had at Valley Health in our community response, the next slide outlines, we created a substance abuse task force, and our work is very much paralleled and supported the community effort. We've been careful not to have redundancy to our effort. We've been careful to try adding expertise where we can and learning where we can, and been very complimentary of the work being done by the broader coalition that we were an active part of. One of the things that we've had, and we've been very fortunate to have, is unwavering support from our governance of Winchester Medical Center and Valley Health, from our CEO and COO, Mark Merrill and Skip Phillips, have both been staunch supporters of our efforts, tireless in their support and unwavering in everything we've been doing. And our medical staff leadership likewise has been engaged, and that makes a big difference, as all you work at healthcare systems realize. When you have all that alignment behind an initiative, a lot of good things can happen. We very much championed, both internally and externally, that this is a neurobiologic disease, and as you see, we try keeping that as a frame of mind and in the forefront of all our initiatives. And we realized we needed and did an educational program that was inside Valley Health. It was created and implemented by members of our task force and was very successful in terms of communicating the message and helping people understand not only the disease but also maybe their own personal situations with disease, with the disease of addiction, and those were all things that we did. Moving along, we'll go to a chronologic order on the next slide, which shows that in April of 2014, Kevin mentioned earlier some of the different summits that we had. And at Shenandoah University, there was a summit that was attended by about 200 people. And that represented the U.S. Attorney's Office, the DEA, Valley Health, local law enforcement, and concerned community members. And Kevin was our leader at that meeting. They broke up by regions. The prior meeting, they kind of broke up by disciplines, and the disciplines weren't all robustly present. And in this one, we had great attendance, and we broke up by regions. And at the end of our local Winchester-Frederick County discussion, Kevin made the very simple question of who's in. You know, if you're going to be a part of creating a solution here, leave your business card on the table. And then Kevin was the guy who got stuck picking up all the business cards. And Kevin then became our leader and gathered that group back up, and a lot of this work was born out of that day. At WMC and at Valley Health, we implemented a system-wide program to ensure proper prescriptive patterns in all our emergency departments and our urgent care centers. And as Secretary Hazel mentioned in his introductory comments, this is an important role that we of health systems have. We emphasized appropriate dispensing of medications, use of the PMP by prescribers, and patient and family education. And we rolled that out in June 1st of 2014. And we made a conscious effort to let all the neighboring health systems, other emergency rooms that may be impacted by patient selection as a result of this program, know what we were doing in advance, prepare for it if they'd like to, and also shared some of our educational materials with them. We also partnered to develop a lot of informational resources, access, and visibility to community organizations and different programs, and tried getting people to understand where the resources were. We're not an area that has rich resources for addiction and substance abuse services, but those that we do have, we needed to make sure were adequately known to people seeking them. One of the good things that came out of the early efforts was increased data sharing. The data that you saw was some of the early data we've updated is that we did data across domains. So we're sharing the judicial system, law enforcement, social services, healthcare, pulling them all together and trying to look at the big picture so we could truly understand the societal impact that we were having. And we continued a lot of local and state advocacy for drug-exposed newborns. The next two slides we'll just briefly go through. This is just a quick snapshot of the brochure that's given to all the patients as they come through the emergency room or any of our urgent care centers. The second of these two slides provides some of the informational to them. This is a brochure that we were able to create here and have had good luck and excellent results in doing this. And the implementation of this at first, we were concerned was going to be a fairly painful experience. And it was embraced by staff, embraced by the medical staff, and quite frankly, in many ways, embraced by patients and their families. So it was a successful campaign all along. The next slide talks about another type of campaign that we had, which was our educational. And these are campaign internally. This is just a sampling of some of the topics that we did. The group internally created a monthly brown bag luncheon that was also telecast to all our 6 hospitals. And these are some of the things I talked about, basic education around substance abuse disorder, the impaired provider, we talked about that, coworker, and how to work at helping them seek help for their addiction. Talked again about medication safety and the RX123 program, which we rolled out here in conjunction with a lot of our local pharmacies. And then people that work here are part of our community, and our community is afflicted by substance abuse, and our employees are. And so we reached out to them and their families about incarceration, about other ways that they can seek help. Tim came and gave a talk about the legal system and how it proceeds. In the next slide, Tim will tell you a little bit about some of our early work in July 2014.
So in July, that was a pretty critical point for us. We'd drawn together, we'd had meetings that were well attended. There was obviously community interest in wanting to really delve into this problem and find solutions. And in July of 2014, we reached out to Casey Family Programs. Judge Kellis had some connection there, and she had contact with Joan All at Casey. Casey Family Programs is the nation's largest operating foundation focused on safely reducing the need for foster care and building communities of hope for families and children across the nation. They typically focus their efforts at a statewide level on impacting policies that affect children at the state level. So our partnership with them, or their helping of us, was fairly unique, but they brought to the table some just invaluable technical assistance and some resources that really helped focus our effort and help the progress that we'll talk about in a few minutes in terms of a community summit that we pulled together.
The outreach that we did around substance abuse and addiction, we launched several initiatives from Valley Health's perspective to, again, try getting the message out around this crisis that we were facing. We have a magazine that goes out to our catchment area in 115,000 different households. And we use that as a tool to create community education on safe medication management, safe medication practices, taking medicines as prescribed, disposing of them, places you can dispose of them, and we increase those resources as well. We actively engaged our health and safety fairs, our trauma fair, to have outreach booths, so to speak, on an educational basis for the community. And we were very active using Valley Health social media to likewise put out the message. And as we created products, videos, etc., that was one of the ways that we would push things out. The next slide, in September of 2014, Valley Health sponsored an educational forum where we had 200 local providers come, and we had representatives that helped speak there from the local law enforcement community, the Virginia State Police, the DEA, about opioid heroin crisis in our community, and educate about the PMP, educate about the connection between the opioids and heroin. Had an excellent discussion with law enforcement and some of our physicians, particularly emergency room physicians, regarding the process by which to manage things on an ongoing basis. And it gave real first-hand opportunity for the physicians and the law enforcement community to address issues and concerns and come up with creative solutions on how to work together collaboratively. We also had Addiction Awareness Month at Valley Health employees and launched an educational program for the staff and medical staff on best practices, and spent a good bit of time promoting the PMP, which you'll hear about later in today's webinar. Kevin will now take us through the next few months.
Yeah, as we said, there was a lot of activity going on, and we're kind of running through it very quickly. But one of the things we quickly recognized is, though heroin was identified as a problem, the real source of the issue was opioid-based pain prescription medications that had been being overprescribed. And then we contacted a number of victims that had first become involved in heroin through their pain medication and then for whatever reason, heroin became either cheaper or more available to them, and they switched to heroin. So one of the things we decided we wanted to do was start working on getting prescription medications out of the households. We were receiving a number of reports of thefts where drugs were being taken from homes. So Nick mentioned the 123 program. Well, the number 3 in that is after you use prescriptions, dispose of them appropriately. And there's been a number of DEA drug takebacks that occurred once or twice a year. They were always very successful, and we decided we'd really like to have an ongoing program of that, those drug takebacks going on. So we discovered that CVS offered a grant where they would award to the police departments a drug take-back box, which is basically a big red strong mailbox that goes in front of our department. We were fortunate enough to receive one of those boxes, and when we first initiated the program, we were getting 50 to 60 pounds of drugs back every week. We figured that was just the result of the novelty of the program, and we'd see that diminish, but we really have not. We continue to get between 30 and 40 pounds of drugs placed in that box every week. And due to the success of that program, our other local law enforcement partners in the community have expanded that program as well. And now we have drug boxes at Frederick County Sheriff's Office, Clark County Sheriff's Office, as well as the City of Winchester, their Sheriff's Office, which they have at the court.
One of the things that we did from a Valley Health perspective is help partner in a lot of the advertising and promotion of this. We heavily promoted the prescription take-back program that the state police were doing in conjunction with the DEA, to the point where the amount of prescriptions brought back, the amount of narcotics returned, actually created a logistics issue for the state police in terms of moving that amount of medication to its point of destruction, which I believe is about 50 miles away or so. They had to kind of retool because they never had so much brought back. We promoted the box that the chief talked about, and the RX123 Valley Health designed the logo for that and went into partnership with Clean, one of our local initiatives. And if you go to many pharmacies, ours was the first, and then many other pharmacies now we have it, where your prescription comes with a sticker with the take as prescribed, and properly dispense, and how to go about properly dispose of, rather how to go about disposing your medications. And so that public education has continued to this day. We also added medication lock boxes. We learned that from the group in Chesterfield. They were ahead of us, and we had our initial phone call was a group in Chesterfield, Virginia, and they had prescription medications that was highly successful for them, and Valley Pharmacy led that in this area, and then other pharmacies have subsidized with that. Tim will take us through now our meeting in November of 2014.
So this was really a seminal moment in our effort. As both Kevin and Nick have been describing, we spent a great deal of time over the summer and into the fall of 2014 pursuing these efforts they've just described, but also collecting a lot of data and reaching out to other communities across the country, literally, to find out what they had done to address addiction and substance abuse crises in their communities. From San Diego to Memphis, Nick mentioned Chesterfield. We gathered information from all over and try to put this all together with Casey's tremendous help to this summit that we held on November 18th, 2014 here at Winchester Medical Center. And what we did is we invited key stakeholders and decision makers in the community. We targeted the Board of Supervisors from the counties, members of the local city council, police chiefs, superintendents of schools, substance abuse providers, representatives from our community services board, social service departments, people that had been dealing with this problem directly, but that also could impact and affect decisions and money in terms of trying to address the problem. And if you could flip to the next slide, one of the ways we started was by presenting them with their own mission and vision statements. We literally went onto the websites and pulled these off and opened our summit with them. I'm not going to read each and every one, but you can see that there's a common theme throughout in terms of safe, vibrant community, high quality of life, improving health, guiding people through their life's challenges, etc. So we were trying to kind of hit them over the head and meet right off the bat with the fact that these were their shared values and that they needed to fall back on those in trying to deal with this crisis that was affecting this community. So to the next slide, please. So again, with Casey's help, we pulled together, we had over 100 people here. The hospital hosted it, Winchester Medical Center provided lunch. We put together a program where we went through some of the slides we just showed here earlier today, but additional ones to really try to hit home how the problem was affecting every spectrum of society, from criminal justice, social services, schools, jail, the treatment providers were all affected. And it was pretty well received. At that summit, next slide, please. We also launched a website called theroadtorecovery.info that's still up and running and is maintained. And this is a resource for folks in our community. Anybody can log on and get information about how to identify substance abuse problems, where to turn for help. We don't make recommendations, but we list a number of providers in not only in the Winchester, Frederick, Clark area, but in adjoining states where people can reach out to help. We also maintain a number on the number of deaths in our community. And as was mentioned earlier, at the time we launched this in 2014, we were 30 plus, and we're currently at 6 for this year, which would for all if we stayed that number. But we wanted the public to be aware of the progress we were making.
On the next slide shows one of the other features that we brought in at the summit. And once we had personalized the story, and those of you who do go to the roadtorecovery.info website, on the bottom left-hand corner of the videos, there's a series of videos on the home page. There's a video that we used to bring home the story where we had a couple talking about the loss of their child, a physician talking about significant disruption of their career as a result of substance abuse, and another individual talking about the impact that it's had on his family. And they were all people known to the community that drove the story home. And between the story and the data that we shared and tapping into the shared missions and commonality of missions, we asked them to adopt what would be a future state as a community. So this group of 100 leaders adopted the statement that you see on this slide, and it was basically by January 2017 to set some modest but achievable modest but achievable goals. We wanted to see a decrease in mortality, a decrease in the incidence of substance-exposed infants, decrease in the incidence of children needing social service intervention due to parental or caregiver addiction, and a decrease in the incidence of crime attributable to addiction. And these were the goals that we did. We talked a lot about how much of a decrease, and you know, what we decided to do is we wanted to make these substantive and achievable. And we wanted to halt the rise as our initial thing and then start trending backwards. And these are the bullets that the community adopted to guide us. Tim presented on the next slide what we viewed as best practice recommendations from our work to date to that summit, and he'll walk through those.
Right. As I mentioned, we reached out to various communities. We had a work group that came out of our original group back in April of 2014. We broke into subcommittees. One of those was called the Best Practices Subcommittee. And we spent the summer of 2014 fall, again, researching and looking at different things that were being done across the country. And this is what we came up with. We wanted to present the group at the summit with not only our desired future state, our measurable goals, but also a way to get there. These were things that we thought could be implemented. Some are obviously outside of our control, but some could easily be implemented in the community to start turning back the tide. So we could start with prevention and education programs, which we felt were absolutely critical. And that would include anything from public service announcements to accessing social media and programs in schools to educate young people about the dangers of opioid addiction, but also substance abuse and addiction in general. Because we also realized early on that while we're experiencing a tremendous problem with opioids and heroin, that at its core it was really a substance abuse and addiction problem, and the problem was going to continue. So we needed to be able to address it at a larger scale. We also focused on medical education programs. Nick had talked about the program that had been sponsored for doctors, but we wanted to reach out to those that were actually treating patients and prescribing the medications and it was geared towards really addressing the prescribing habits. Drug take-back programs has already been referenced, the boxes that Kevin mentioned, the RX-123 program. And then treatment and detox programs. We wanted to take a good hard look at what we had available in our community, and we realized that we were lacking in some significant areas, detox being one of them, inpatient treatment programs. And although we have a number of private providers who have stepped forward and helped our effort, getting accessible and affordable treatment for people in the throes of addiction was tough. And that was an area that we were really going to have to focus on and address. We identified the prescription monitoring program as critical to, that I know Ralph is going to speak about later in this webinar, but just encouraging physicians and dispensers to look at the prescription monitoring program and try to get a handle on for any abuses that might be occurring. Drug courts. We identified drug treatment courts as an area that we desperately wanted to implement in our community, and that was based on a number of things. The fact that they've been around for 20 years, we've never had one in our area. So we had to change some mindsets amongst the criminal justice community and to really try to take steps to implement that. Part of what we did is we relied on data from the General Assembly and a 2012 cost-benefit analysis that showed drug courts, the 12 studied at that time in Virginia, saved nearly $20,000 per participant relative to the cost of doing business as usual, which would typically involve putting people in jail and on probation. And there's great cost in that, in incarceration, but also in recidivism, future victimization, and we could achieve great savings if we were able to implement a drug court. And then we need transitional care after incarceration, and then also tapping a peer recovery network. We realized maybe later than we should have how important the recovery community was going to be to our efforts. And we really needed to utilize that community and tap in to them to get them to help in the effort.
Next slide, please. Yeah, I want to remind you that all this activity was going on basically over a 6-month period or 7-month period from May of 2014 through January of 2015. And we came to the realization very quickly that we needed help. We were all doing this as part of our night duties, I guess. We all had day jobs that were keeping us very busy, and this was a significant volunteer effort on everybody's part. So we really decided, and that effort was done under what we were calling the Addiction Action Committee at the time. So we really decided after that November seminar that we needed to get more formalized. If we were really going to succeed in moving forward, we were going to need some significant funding. So we decided at some point to develop what has become known as the Northern Shenandoah Valley Substance Abuse Coalition. So in January of 2015, we decided that would be our name. We wanted the concept of the coalition really to expand what we've been doing, because we thought the committee was very limiting, and we wanted to include not just addiction but substance abuse as well. Because if you look at the trends in these sort of things, generally a drug will have a trend of about 5 years, and then it'll lose its popularity and a new drug will come along. So we really wanted to position our community to be beyond the heroin addiction and be looking at the next drug coming on. So we did develop a charter. We sought 501(c)(3) status through the IRS and formulated our organization more formally. We also decided if we needed some funding, we needed some additional support. So we started reaching out to leadership within our community. We met with our local congressperson, Congresswoman Comstock. We met with our local senator, Senator Vogel, as well as the Community Services Board, trying to look to what opportunities are there for funding for us and how do we get their support in seeking those funding opportunities.
On the next slide, we talk a little bit about a community forum we held, and we had 125 community members attend this forum. And at that forum, we had several different presentations with several different messages. One of the most powerful was the most powerful was a message of hope from a recovering addict. For me personally, that was one of the points of realization that's been mentioned already is the importance to focus on recovery and to include the recovery community in your efforts. And it's really an inspirational story that this young man shared with the group there. We also presented the data that we had used at the November 2014 summit, where we had the community leaders, and by showing them a sense of our current reality, we were able to build cohesion amongst them to move forward towards a common goal. We did the same with the community, and this event was covered by our local media. And our idea was that we needed to move the community's minds as well and get them behind this, because as Tim mentioned earlier, there was mindset change that needed to change in the criminal justice system with some of our local state legislators, and we needed to make sure that the community understood the reality, and we took that opportunity to educate the community about the reality at that point. We had a member of the Northwest Regional Drug Task Force give a very insightful talk, very helpful to anybody that's worried about whether or not there's substance abuse going on in their home or in their work environment, as an educational matter. And then we had an hour-plus long Q&A session, which gave us an excellent opportunity for community feedback for our initiatives, strategies that perhaps we needed to consider. Another thing that happened in March of 2015 is that Valley Health, working with our Community Service Board, created a jointly funded perinatal substance abuse case manager. And that has been a wonderful, successful program that we've done jointly with the CSB. We don't have a robustly funded CSB, and this is one area where we were able to collaborate with them and accomplish, I think, very positive outcomes for the community, where moms are identified at their OB visit, and they test positive the OB visit. They're referred to see the addiction counselor, who can then do the initial appointment with them and triage them into the appropriate care setting to try working with them prior, while they're pregnant and prior to delivery, to try minimizing the impact on the children. It's been a very good program, and we're beginning now to create some metrics around its efficacy. Tim will take us from April on.
So the next slide shows we're in April 2015 now, so we're really about a year into this concerted effort where we were becoming more organized. And this was an example of another educational forum we sponsored and put on for the community. And the advertising for these things wasn't great. We weren't paying for advertising, we were putting word out, yet we were getting tremendous community response. This particular one was entitled "Your Kids Know More Than You Do," about drugs and drug abuse. Had over 150 people show up at the local high school. Dr. Will Rushton, an emergency room physician, poison control expert from Charlottesville, UVA, came and just gave at times heady presentation about substances and chemicals, but giving us not just on opiates and heroin, but, as Kevin was saying, the next thing to come along in terms of synthetic drugs, K2, spice, and things like that. But it was really an effort to educate the community about what's going on, and it exists here. Also in April, we convened the organizational meeting of the Winchester Frederick Clark Drug Treatment Court Advisory Committee. That one thing we didn't mention was that in addition to contacting our federal and state legislators, we also met with our local elected officials. We met with city council members. We met with Frederick County Board of Supervisors in Clark County and engaged them one-on-one about the effort. And it was clear to us that one of the things they really took from the summit in November was the establishment of a drug treatment court. That really gained some interest and momentum. And so we pulled together the meeting of this advisory committee that's required by state code to establish the committee. And then next slide, please. We also then went and actually visited in the Commonwealth. Different of us who were available went and sat in on their sessions. These were day-long field trips, if you will, but we gained a lot of insight and a lot of information into how the courts actually worked, because they were new to this community. While they've existed for some time in Virginia, they didn't exist here. So we had to educate ourselves so that we could then bring that information back and spread that word to others. And also in May, we became incorporated as a Virginia nonprofit corporation, and as Kevin mentioned, we also obtained 501c3 status from the IRS.
Yeah, we were fortunate, we got an indication finally that somebody was listening. After all our meetings with local leadership, the state leadership, the national leadership, we did get some interest from our local board of supervisors and city council saying, hey, we hear you guys, we recognize the problem in our community, what can we do to help? And they're willing to put some funding behind that. The city of Winchester and Frederick County each came up with $60,000 for this fiscal year. The Clark County, which is a much smaller county, gave what they believe was a proportional effort with $15,000, and Valley Health, who has been a great partner with us, throughout this whole effort, met with an additional $60,000. That gave us enough funding to hire an executive director to do many of the things that we were all doing on our own time, and really has given us the opportunity now to move forward. So we started with that hiring process in July of 2015, and the direction we got from the local board of supervisors and the city council was that we really support this idea of a drug court, and that's going to be the primary duty of our executive director, is to get that drug court established. So that's what we've been moving towards in the last 6 or 7 months.
In September of 2015, as the next slide states, we created an educational forum that 160 physicians attended, and it was on pain management. We brought a speaker from the University of Virginia School of Medicine and had an excellent presentation on pain management strategies, alternatives to opiates, and it was very well attended and very much engaged with both primary care physicians and specialists, and it was very much a success. And part of it, again, as Secretary Hazel mentioned, the need to look at the reliance on opioids as a pain treatment method. We also had a community program that we sponsored, hosted here at the hospital, and done with members of the coalition as well as Valley Health Substance Abuse Committee. And it was a community program on different addiction treatment options with different treatment providers speaking and different members of the recovery community speaking there as well. In October, we were fortunate enough to have a grant through the KC Family Programs that enabled us to have the McShin Foundation do a peer-to-peer recovery coaching training program that was hosted down at the police department and has had some subsequent follow-up training as well. Again, trying to set the stage for some of the necessary components for a successful drug treatment court, and also looking at some other alternative uses for peer-to-peer recovery coaching as we move forward. In October, we also went with KC. They funded a visit for many of us to attend the Philadelphia Drug Treatment Court in Pennsylvania. It's a large, high-volume, long-established, successful drug treatment court there with some of the same challenges we have in terms of limited treatment resources for the underinsured or the uninsured. And they, like us, have had to put together a creative strategy amongst themselves to get treatment for several hundred clients at each time within the drug treatment court. And then Tim will take us through November.
So the next slide will kind of round out our timeline, and then we'll get into a few other areas. But in November, we actually extended an offer for the executive director, Lauren Cummings, who came on, officially started work in January of 2016. In actually late February, we submitted our application to the Virginia Supreme Court for approval to start our drug treatment court, and that is pending. We hope there's a meeting next week, and we hope to get approval to start up by July 1st. And just last week, the drug treatment court team attended the National Drug Court Institute training, which was 3 days, and that was held down in Lynchburg. So a lot of our more recent efforts have been focused on getting the drug treatment court up and running, while we're trying to hit a lot of the other prevention, education, recovery areas as well.
On the next slide, Kevin will take us through our strategic planning retreat and the outcome of that retreat that again was helped facilitated by Casey.
I'm sure we've bored you and sent your head spinning with all the activity we've done the last year and a half. But we always like to stop and take our temperature, and at the end of the last year we decided, are we meeting our goals? How do we progress in the future? Are we on track? So we decided that we really needed to sit down and have a strategic planning retreat. We did so with the support, again, of the Casey Foundation, who not only gave us some financial support for that, but actually came in from the West Coast. They had several people come in from the West Coast to facilitate that discussion. And from that discussion, we really came away with a mission statement. And one of the things that we'll talk about in a minute is some of the things we discovered as a weakness. One of the things we discovered was that we were not including the recovery community in our discussions. And they are such a vital link that we tried to rectify that at this strategic session by bringing them in and kind of running our mission statement that we developed by them to get their ideas to see if we're on track. And I'm happy to report they said we were. And as you can see on your slide here, on the next slide is our mission statement that was developed as a result of that retreat. And it says the Northern Shenandoah Valley Substance Abuse Coalition will collaborate, and I think that's an important word, is that collaboration with community partners to take the lead in identifying and developing effective resources to ensure that the necessary continuum of care for substance abuse and addiction services is available to all members of the community. And the real struggle with that was we wanted to make it clear that we were not going to provide these services, that we were not cutting into anybody in any of our other partners' turf. We just wanted to be the collaborative umbrella, if you resources are being used appropriately. Struggle with our mission statement, I believe, was there. And then we went on and developed a vision statement, which is our next slide, which says working together to overcome the grip of substance abuse and addiction. And that is really our goal for the future. We also at that retreat developed some strategic focus areas that we're going to concentrate on in the future. Again, to get us those selected desired future states we'd mentioned earlier, and that's included in the next slide. And this goes back to our first discussion I mentioned with the drug, with our drug force. We said it was a three-legged stool. We've kind of cut out enforcement because we're doing a good job on that ourselves in the law enforcement community, but we really wanted to focus on prevention, treatment, and recovery. So we developed a couple of ideas under the concept of prevention, and it's really, we want to create a new community norm in terms of substance abuse. And finally, and the next point is we want to age-appropriate and situationally appropriate education offered all longitudinally. And that's been one big challenge because despite all our best practices research, all the efforts we've made to try to find the most appropriate tasks to follow, you know, there really aren't any good programs available that we've been able to discover that are the number one way to prevent substance abuse in our community. And so that's one area we're really hoping to develop in the future. And it's very challenging because, as I said, we know that there's another epidemic coming in the future. It may not be heroin, but it's going to be another drug. And how do we reach down to those kids that are thinking about using drugs and prevent that from happening? So that's going to be a big challenge for us in the future. We are looking at treatment, and it's treatment that is financially and geographically accessible in a timely manner. One of the things that's missing in our community is a good treatment program. For example, we have no recovery facility here in our community. So we really like to develop those sort of things. And we want to make sure we're client-focused with individualized treatment that includes family support. Because if we forget about the family, we're just throwing that person right back into the same environment that probably helped foster the addiction to begin with. And finally, we want to look at recovery. And those resources are available to anyone who reaches out to our coalition with substance abuse disorder issues. And then we want a robust peer recovery coaching program. And that goes back to my comments about, you know, we kind of forgot the recovery community. And they can be such a vital link in helping us get help to people that are seeking assistance with recovery. So we don't want to forget about them.
I'll circle back on one issue there around the treatment. As Kevin mentioned, we don't have a robust treatment community. And what we've done recently, the coalition has created a treatment resource survey that we've pushed out. We've received back from all our local treatment providers that's essentially looking at what we do and don't have. And Kate Newhausen from Virginia Medicaid, the chief medical officer, has been instrumental in helping guide us as we look at that and has put us in touch with some other resources now as we begin to analyze what we need as a community to develop in the future so that we can meet that bullet of financially and geographically accessible care in a timely manner. The next few slides, we'll talk about the key drivers of early success and our lessons learned. On the first of those subsequent slides are bullets 1 and 2. And what we've put together here are some of our early successes and lessons learned. I think it's extraordinarily important for everybody to realize that the need to educate and engage your community as a whole and the leaders of your community. We believe it's key to collect and share the data, to put a face on the crisis so that people come to understand there's a very personal crisis that's impacting your friends, neighbors, and as Secretary Hazel said, it really knows no boundaries. And to shine a light on the hope of recovery. It's quite frankly real easy to get down if you're always focused on addiction. But if you have that light of recovery and the hope that recovery brings, that helps engage the community and move you forward in a productive manner. We believe it's vitally important to have an education strategy as you begin to tackle the community. And that education has to be to a wide variety of people and meet their needs. You have to look at the providers of health care, your elected leaders, and the general public, And again, as we've mentioned, we've gone about doing that in order to try to help them understand the crisis that we face and the potential solutions that we need to move towards. On the next slide, I go through a few more bullets. And the first one's a very vitally important one. And that is, we as a group believe firmly that addiction's a disease, that this is a public health crisis. We were led there by our law enforcement, who came to us and said, we can't arrest our way out of this crisis. And we as a community have listened to that, have embraced that, and have championed that in all of our initiatives. To establish a multidisciplinary cross-systems approach. We have a very diverse group. We are 3 leaders of a group of about 6 or 7 that includes other members of our team, Chris Rucker, who works as the president of Valley Regional Enterprise, Judge Kellis, who was mentioned earlier, he's one of our juvenile and domestic court judges. Steve Kluss is a local retired businessman, a member of our boards. We are just a leadership group of a much broader initiative on a monthly basis, including this afternoon. The chief holds a meeting of the broader coalition, and it represents all disciplines, all systems within a community and within a society. And I think it's important. We have education at the table. We have, you name it, they're there. We believe it's very important to establish realistic and concrete goals and to share those and then work towards them together as a community. And whenever the media wants to talk about this, pounce on it. It's important to keep in the front of the media, keep it in the forefront of your community, and use the media in a positive manner to communicate around this. We also believe, and we think we learned this, quite frankly, almost tripped on our way there, in terms of the need to include both the recovery and faith-based communities early. That was something we weren't quick to do. We learned that we needed to do that, and we've now corrected course with regards to that. Finally, on the stakeholder side, and there's a diverse group of registrants for today's meeting, and it's not just healthcare systems or people from all these cross systems exist on today's call. Take a look at yourself and your organization. What can you contribute from a time, talent, and treasure standpoint to your broader community effort? And I think our health systems distributed the ability to demonstrate how all these can be a part of creating a solution together. Very important that any stakeholder can champion your community's understanding that you're dealing with the disease of addiction. Again, educate providers in your community about appropriate use of opioid analgesics and alternative forms of pain management. Champion the community drug take-back programs, whether they be the DEA's programs that they have or whether your local law enforcement applies for one of the CVS grants to get the free box outside the police station. Go ahead, get it, and then promote it. And you need to facilitate and look at what your role can be in getting naloxone out in the community, whether it be helping support educational programs for its proper use, working with a pharmacy for its dispensing, working with your local law enforcement agencies to make sure they have access to it. Again, as the chief mentioned earlier, we've already had lives saved as a result of that. And we think it's very important to take a look as a community at what are the unmet needs of the continuum of care in your community and how do you go about together fixing those. So finally, as the last slide shows, we're just at the tip of the iceberg. And what we'd like to leave you with is the message that our work has just begun. But imagine what we can all do if we work together. So we thank you for spending time with us today.
Thank you so much for that valuable information, as well as for all of your efforts in the Northern Shenandoah Valley. We are very grateful for your commitment, the difference that you're making, and for your willingness to share so that others can do the same. To wrap up the content of this session, we have with us Mr. Ralph Orr, the Director of Virginia's Prescription Monitoring Program. Ralph will provide you with some essential information from the Department of Health Professions, as well as information specifically about the PMP. Ralph, thank you for being with us today.
Thank you, Ashley, and thank you to VHHA for putting this together. And boy, it's a tough tough group to follow after the last presentation. But I want to talk about the Virginia Prescription Monitoring Program, and I think I'll start by just saying the purpose of the program, very simply put, is to promote the appropriate use of controlled substances for legitimate medical purposes. And we do that by collecting controlled prescription drug data into a database and then making it available to authorized users, such as prescribers and pharmacists, to assist them in making informed treatment and dispensing decisions. Other users include law enforcement when they have an open investigation, regulatory personnel, and patients over the age of 18 can request and obtain their own prescription history from us. So on the next, and By doing all this, we hope to deter the misuse, abuse, and diversion of the controlled substances. So on the next slide, I'll talk about a few details of what we actually are as a database or a program. And so first of all, we collect Schedule 2, 3, and 4 prescriptions that are dispensed to citizens in Virginia. And Schedule 2 would be the oxycodone, methadone, methylphenidate type of prescription. Schedule 3 would be the Tylenol with codeine, testosterone, those kinds of things. And Schedule 4 would be the benzodiazepines, the Ambiens, and some of those other products. The access to the program is 24/7 for prescribers and pharma. Emergency room that's open on a Saturday morning at 3 o'clock in the morning, that doctor can get on there and request a prescription monitoring report to help them determine the prescription history of a patient that's in the ER and to make an informed decision. Pharmacies and dispensing physicians must report the dispensing of a controlled substance within 7 days, and that includes the mail-order pharmacies that ship into Virginia, and it also includes the 3 Veterans Administration treatment facilities in Virginia, the one in Hampton, Salem, and in Richmond. We do have some exemptions from reporting. Obviously, in a case of an emergency, that's not reportable. The administration of covered substances, dispensing to patients in an inpatient situation, and in the dispensing that occurs in a narcotic maintenance treatment program. One of the big things that we are very proud to be one of the first 3 states in the nation to do is become interoperable with other states. We share a lot of border territory, especially up in the Winchester area, with other states, and we are interoperable with 19 states now, including West Virginia, Kentucky, Tennessee, Maryland, and we just recently added Rhode Island. So we think that's an important key. And the other thing that's going to happen here in the near future, we're working very hard on, is the integration of PMP data into a healthcare system EMR or a pharmacy software application. There are currently 62 Kroger pharmacies that have integrated the PMP data into their pharmacy application. So that's a really nice thing for those folks. This year was a very busy year with the General Assembly. We had, as you see above right now, our pharmacies dispense, they report their dispensing within 7 days. Well, as of January 1st, they're going to start having the report within 24 hours of dispensing. We also added new legislation that requires prescribers to use the prescription monitoring program if they are going to prescribe a controlled substance, an opioid that is going to last more than 14 days, and that becomes effective July 1st. We've also, one of the biggest things that we've done over the years is figure out who needs to have access and how do we make that access easier or more user-friendly to the people that really need it. And one thing we found out is that we have a lot of clinical pharmacists and consulting physicians working that provide information on a healthcare team that did not have access to the prescription monitoring program. So on July 1st, they'll be able to have that kind of access. So we worked very hard on doing those things. I thought I'd spend a few minutes just talking about what is on a PMP report, because I think sometimes there's some questions about that. And so on the very first page of a PMP report, you're going to have some patient information. So the patient information is related to the prescriptions that are on the report. And just because a patient has more than one patient ID does not necessarily mean anything bad or anything meaningful. It just means that they've gone to probably 2 or more pharmacies and received prescriptions within the time period that you're requesting. To the right of that is a very important element that we added to the PMP reports in June of 2015, which is the active cumulative morphine equivalent score. And so this score gives a prescriber or a dispenser at a quick glance an idea of what the active morphine score is for the opiates being prescribed for that patient. So in this case, this patient is receiving a daily morphine equivalent score of 247 milligrams of morphine. And I'll talk a little bit more about that. Now below is all the prescription information. So it will tell you the most recent prescription that was filled and the date. It tells you the product of the name of the drug, the quantity, the day supply, Then it will tell you the patient ID of what address was used for that prescription. It will also tell you an anagram for the prescriber, the date it was written, the prescription number, the daily MED score. This is regardless of whether, if it's an opioid, regardless of whether it's an active prescription or not an active prescription. It will tell you whether it's an active prescription, and that is for any prescription that is on the PMP report. It will tell you if it's a new or a refill, and then it will tell you if it's the pharmacy information and the method of payment. And that becomes really important because you can see on this very first one, the very first prescription for oxycodone, that was the method of payment was private pay. But on the commercial insurance, on motion and alprazolam, an opioid and a benzodiazepine, which actually increases the risk for overdose for that patient. And so that's another thing that we probably should be very concerned about sometimes when we're looking at these things. The other thing, one thing that I would tell prescribers and pharmacists is that this is a compliance tool, so you can confirm the compliance of a treatment program of your patients. You can also confirm the prescription history. So what's very important, we know that sometimes patients will have their little cards that they carry around in their wallet or their purse and say that they're on a particular medication, and when you go and you run the PMP and you start to look at that, you find out that they actually haven't taken an opioid for over 6 months. And if you were to prescribe the opiate at the dose that they had been taking 6 months ago, that may very well put them at risk for overdose. So it's a very important thing to understand that this is first of all, it's free, but it's a great check on what the patient is telling you as far as the prescription history. At the very bottom of the screen, you can see the two prescribers that were listed for this particular patient, and obviously this isn't the patient, the actual prescribers, but it will tell you the name of the prescriber and the general address of where they're located. It's not necessarily their actual practice location, but it will give you a general idea of where they are located. If we could go to the next slide. At the end of the report, below the prescriber information is the pharmacies that dispense the prescriptions listed. In this particular case, you would look and see, and you can see they had two chain pharmacies, a total of 4 stores there that were chain pharmacies, and then 2 independent pharmacies. And sometimes what patients that are having some problems may do is that they might go and go to different pharmacies instead of doctor shopping necessarily, maybe they're pharmacy shopping. So that becomes a real problem. You can start to get an idea. There's several programs that suggest that when you are going to be providing for chronic pain, opioids for chronic pain, you put them in a treatment agreement and restrict the number of prescribers, the number of pharmacies, or identify the pharmacy that can be used under that treatment agreement. Right below the pharmacy information is a statement from CDC that they report that the MEDD score of 100 or more represents a significant increase in overdose risk for patients. This is really important. When you look at the statistics, once a patient gets above 100, the risk for overdose jumps significantly. And that's the only thing that we say on as far as these morphine scores is that at some point when you see, we're not saying that you can't go above 100 morphine equivalents per day. What we're saying is that the patient is experiencing or is likely to occur higher risk for overdose. And so you have to, like within prescribing of a prescription drug, you have to weigh benefits. In methadone, we have the methadone is the multiplier of 3. However, in some patients, and depending on their multiplier should be higher. But this is a generic program, and you have to use your own clinical judgment when you're using this information. And below that is the actual calculations that are used to develop the daily MED score and the cumulative morphine equivalent score. And on the next slide is our contact information. We do encourage people and look at we have forms there. I do want to point out that in addition to pharmacists and prescribers having access to the program, they both have the ability to authorize live delegates to information, and the form is for that. And first, to authorize is for them in their offices who have access to confidential patient information already. So that's going to be a big help, I think, to busy prescribers and pharmacists. So with that, I'll turn this back to Ashley, and thank you very much for your attention.
Ralph, that was really important information to give us those facts and updates. Attendees, submit your questions. Thought-provoking, and our presenters are standing that you have. To submit your questions, simply type them into the question box in your control panel. We will answer as many as possible. Again, there are a lot of you on this call, so we may not get to everyone. But as you post them, I will read the question aloud so that everyone is aware of what is being asked. One of our first questions was, there seems to be some stigma or concerns in our community about medication-assisted treatment. Have you experienced similar concerns in your community, and how did you address them? And I believe that question is more than likely directed to the coalition folks.
Okay, thank you. This is Tim Coyne, Public Defender with the Coalition. We did have to address that in the context of establishing primarily our drug treatment court, driven by federal grant requirements, frankly, that now say that you cannot disallow somebody from participation in a drug treatment court if they're on medication-assisted treatment. So we had to grapple with that. In fact, we did. There were at least several members of the Drug Treatment Court Advisory Committee and team who were concerned about it, because what I see a lot of in my work is abuse of that medication-assisted treatment, Suboxone primarily. So it is susceptible to abuse. But we got the facts. We reached out and got information from the National Drug Court Institute to educate those members of our team on medication-assisted treatment. And again, facing the reality that we're not going to be eligible for grants if we disallow those. And then really the reality that if you step back and look at this as an addiction, and you look at it and treat it that way, that you would not deny a diabetic insulin or a heart patient medication that they need to deal with that. So if there are proven modalities out there that help the addiction, we should be utilizing all of them. And that's how we addressed it.
I would add that I think it's important to look at the fact that it needs to be part of a broader program. Some of the issues you have are around some prescribers that don't necessarily follow the ASAM guidelines and provide other modalities of therapy for the disease. Just like a diabetic, you wouldn't say, here's your insulin, come back in a year, and just keep giving it. You have an ongoing treatment program looking at the broader substance abuse disorder the patient suffers from.
The three of you mentioned the grants from CVS, but have you worked with other pharmacists in the community to recruit them as drug disposal sites? And what were the barriers to this that you experienced, and how did you overcome them?
That's on the disposal side?
Yeah, we have. We've had some great cooperation from the pharmacies. Many of them have joined the 1-2-3 program, which is they have a sticker that goes on the prescription when they issue it saying, the 1-2-3 is use the prescription appropriately, store it safely while you're using it, and then dispose of it when you're done with it. So that's been very helpful. One of the challenges is disposal of the drugs. We've been taking in, as I said, between 30 and 40 pounds a week, and how do you appropriately dispose of that? We have to take it to our animal control facility and incinerate it there. So there are some guidelines according to the DEA that it has to be handled appropriately. You have to maintain the chain of custody, even though it's not evidence, just to make sure it's protected. And those sort of issues all have to be resolved. But we were able to do that pretty effectively.
And as far as, this is Lauren Cummings, I'm the executive director of the Substance Abuse Coalition. As far as the local pharmacies actually collecting your disposals at the pharmacies, none of our local pharmacies currently do. It is my understanding that Walgreens announced that they will be putting in drug collection units across the country. They're starting in California and then moving east. But to date, none of our local pharmacies have drug collection units.
Okay, next question is, have you had any luck engaging large healthcare systems to do training on changes to opioid prescription guidelines for treating pain?
Yeah, so our healthcare system is engaged in education around appropriate use of opioids, both in the emergency department and care setting, and also, as I mentioned with our presentation, looking at primary care offices and the outpatient arena. In terms of is the question more referencing to engaging large healthcare organizations around national prescriptive guidelines?
The question was about large healthcare systems to do training.
That's right.
Yeah, so we're I guess, a medium-sized healthcare system. We're the largest in our region, and we've done a fair amount of local training. What we've not done is, I guess, a question in terms of creating prescriptive guidelines for treating pain. We've done a lot of education. We've done guidelines in the emergency department, but we're looking at, and we haven't yet done this, and this is an area that is somewhat related, is we're looking at alternative pain management approaches using our own workforce. And we've had some discussions with some members of Congress that believe we should potentially look at being a Medicare study site for this, and looking at, as we evaluate patients with pain and their needs for pain, not reflexing to interventions necessarily, or not reflexing to narcotics, but looking at some of the other pain modalities, whether it be acupuncture, Reiki therapy, massage therapy, and trying to get a more holistic approach that, again, moves us towards the direction of not depending upon opioids. But we've not developed guidelines for that just yet. We're in the early phases of that.
Okay, thank you. The next question is, the Department of Health recommends SBIRT as an early intervention strategy. Are there state resources to train providers on integrating this into their practices and organizations?
Yeah. I don't know that I can speak for the state. I can share that the Medical Society of Virginia in Richmond on April 29th at 8:30 in the morning is providing a workshop that some people have mentioned, and also that George Mason University School of Nursing has applied for a substantial grant that we are, Valley Health, has applied with them as a potential site for SBIRT training and implementation. What resources the Commonwealth has, I guess Secretary Hazel or one of the members of his team would probably be best equipped to answer that.
Secretary Hazel, did you want to address that?
I will be honest with you, I did not hear the full question. So could you ask it again?
The Department of Health recommends SBIRT as an early intervention strategy. Are there state resources to train providers on integrating this into their practices and organizations?
I am not aware of state resources per se for integration into practice of this at this point in time.
Okay, thank you very much. A question to
Ashley, this is Ralph. I think that there are resources available through SAMHSA, the Substance Abuse Mental Health Services Administration, and I believe that's through their PCCS website. So there are some things that you can find out from there that are readily available.
Wonderful. Thank you so much. A quick question for the coalition. What is the biggest mistake that you have made? And similarly, maybe it's a different answer, but what is the biggest obstacle that you have faced?
I think, this is Tim Coyne for the Coalition. I think probably the biggest mistake we made, as we referenced in our presentation, was not engaging the recovery community early enough in the process. We knew they were there, the AA, NA, but there's a broader recovery community here, and just not getting them actively involved in our efforts from the very early stages. So that was probably the biggest mistake. One of the biggest challenges has been securing funding. We've had to rely heavily on our localities who have been very generous in Valley Health and the help we've gotten from Casey Family Programs, but just trying to tap into sufficient resources that will allow, for example, the drug court to continue. When we can get it up and running by July 1, then the question becomes how to sustain it. State dollars are limited. There was some additional money in the governor's budget this year for drug treatment courts. However, we just have to figure out how to keep it going. And then probably another as large an area of challenge is our Community Services Board. It's underfunded, as it is in many areas. Local dollars aren't as heavy as in, say, Fairfax or Loudoun, and our local CSB has had to really cut substance abuse treatment services in recent years. So we've been engaging them to try to come up with creative ways that they can get those services reinstated and serving the community again.
All right, thank you. Attendees, just to let you know, we have a number of questions coming in from you, and we really appreciate it. So we are reaching our time limit, but we would like to keep going. So we are getting to your questions as quickly as possible. We have a question from one of our listeners. Are there any legal ramifications for patients who engage in doctor or pharmacy shopping? Does the pharmacy notify the doctor when that happens?
Yes, there are a number of ramifications that most of them are actually using forged prescriptions, where they will get a prescription pad from a physician or print one out themselves and take it to the pharmacy and try passing on as legitimate. There are duplication, of legitimate prescriptions, all those sort of things, all of which are in violation of Virginia law. The fact that Virginia State Police has a unit that does nothing but monitor this type of activity, and they will pursue offenders. So the ramifications are quite severe if you're caught.
Thank you. We have another question. Drug courts have not been proven to have successful outcomes based on some of the research. How do you ensure positive outcomes?
This is Secretary Hazel. I think there's now abundant research that shows that drug courts are successful in reducing recidivism compared to those who go through more standard incarceration. So the premise there that it doesn't work, to me, is not correct. I can tell you that I've had the pleasure of attending a drug court graduation in Tazewell each of the last 2 years. Judge Hurley down there, I'll give you one measure of success. He has had 12 babies born drug-free into his program. And in addition, the numbers do show that it is beneficial.
And I would just add to the Secretary's comment, Tim Coyne again, that the 2012 study done by the National Center for State Courts, again, clearly shows that those 12 drug courts that were studied saved nearly $20,000 per participant, and they do have very, very good success rates.
Okay, another question. How is naloxone use with patient outcomes, survive versus death, being recorded and or monitored between EMS, hospitals, etc.? And second part of the question is, how accurate is the current system of tracking for the usage of naloxone?
We regionally here are just establishing that. So Chris Rucker, who's one of the members of our leadership group, is our liaison with our local EMS community, and working with them and law enforcement has just recently been introduced in our law enforcement community locally. We're just now in the process of creating a tracking process for that. So the answer is it's not well tracked, it's not well monitored, and the desired state that we're working towards is to create a mechanism by which we will be able to track that and be able to establish success rather than just anecdotal stories, but actually specific data. So we're in the process of developing that.
Can someone from the coalition please articulate how the experience of individuals who are dealing with addiction and seeking treatment differs based on whether those individuals have health insurance?
Significantly. In our area and throughout the Commonwealth, as you may have noticed on our slide, and part of our goal is to make sure we meet everybody's needs, both geographically and with regards to their means. And there's the uninsured population, there's the underinsured population, and then there's the well-insured population. Our area, quite frankly, they're all challenged due to resource limitations. But if you have the means by which to travel outside the great, Winchester, Frederick County area, and insurance that'll cover for that, you'll have good access to care in a variety of places. Whereas absent that, you won't. And people are looking at different community recovery organizations. There's models in Richmond and elsewhere where a less costly mechanism of care or system of care exists. And depending upon which one of the organizations you're looking at, with variable outcomes. This is a very difficult disease to establish great outcomes in, but there are other ways of approaching it, and there are ways that we're looking at as we get together here in the coming months of creating a community treatment program collaboratively with all the different treatment providers that will need to address the people both of means and without the means to be able to support that.
And I'll just add, my clients are indigent. So it's rare the client I have that has any access to insurance. And so the only treatment that's accessible was that 90-day program that I mentioned in the presentation. Problem is you have to be incarcerated to go through it. And that's the real shame of it. It's a great program, but it serves only the population.
And as Tim mentioned earlier, our area is not like Fairfax County or Loudoun County where you have a robust CSB. We have far from a robust CSB. And so that entire section of our community is under or poorly served.
And one slide we did not include that we've used previously is I think about 2/3 of the people who were admitted to our hospital here with addiction issues were either on Medicare or not insured.
Mm-hmm. This is Secretary Hazel. I'd like to speak to that. Individuals with addiction do have additional issues besides their addiction. We see a high prevalence of, for instance, hepatitis. In fact, in some areas of the country, we've had significant hepatitis outbreaks, and you may know that some of those medications now for hepatitis C are costing $93,000, $94,000 for an episode of treatment. We clearly have to be very mindful of the medical issues as well, and clearly those who do not have means of paying are at significant risk. The issues with the treatment of the addiction itself is something that we have tried to address. Unfortunately, if had a Medicaid expansion occurred, we would have brought about $200 million a year into the system to pay for mental health treatment, significant coexisting conditions in mental health and substance abuse. We are looking at the substance use disorder waiver, which will be for people who are Medicaid eligible. We also are trying to address the workforce issues that the sort of lack of expertise in many areas in addiction treatment. I do think, though, that an area, and the gentleman mentioned it earlier, one thing that I think we have failed to do significantly is engage our peer community, and do not underestimate the power of the peer community in helping in treatment.
A question from one of our listeners. The Virginia Board of Pharmacy has asked pharmacies in our community to remove them based on Virginia regulations. Is that why the collection boxes are at the law enforcement offices?
Yes, it's DEA regulations. They have to be at a law enforcement facility, and there's a number of other restrictions that apply as well. So that's probably the reason behind that.
If I could, there are some DEA rules about collection. Those are not Department of Health Professions, nor are they VDH rules. I do believe I've looked into the issue related to the Walgreens desires to have the collection boxes in all of their stores, and I have been told, at least by our health professions and pharmacy boards, that we have no rules that would prohibit that at this time.
Do you see societal explanations for the addiction problem as well as physiological reasons for the problem?
Yeah. We absolutely we do.
Could you elaborate on that a little bit?
It is a multifactorial disease that is still increasingly being understood. But there are clearly precipitating factors, like any other disease, that societal factors, socioeconomic factors, life stressors impact. And similar to if you look at the demographic characteristics of a diabetic population, there's going to be certain factors that will impact that. And addiction is no different as a disease. It's not just boy, you have this gene and therefore you have this addiction. It's a predilection for this neurobiologic disease, and other factors contribute to that in life and in your place in society and the different challenges that you face on a daily basis.
Thank you. I am a social worker on the OB and NICU and work closely with, it says, NP and NEOs who can address the PMP. Do practitioners advise their patients that these records are being reviewed? And do hospitals have to alert the patient when reviewing their PMP?
Yep, I'm a prescriber or area. It can be by providing written material or actually obtaining the actual consent. There's some kind of notification that has a process.
We're seeing
go ahead.
Is that we're seeing increasingly practices, office sites, clinic sites, emergency rooms, and notifying patients that this is how we do we do that.
Yeah.
Thank you. Most substance programs require a person to be quote unquote clean with no available detox centers. What options are there for someone wanting to be detox help?
Well, unfortunately, you get a rate we have in our region, and that's unfortunate. And that's one of the things we hope to do is capture people before they become involved in the criminal justice system. As effective as the drug court is, it's far more effective to catch them and get them involved before they ever become involved with the law.
And in some parts of the Commonwealth, in our health system, we end up detoxing a fair number of people that have comorbidities. So they have some other reason for being in the hospital. We're detoxing people daily like that. We do not have a straight primary detox unit at this point. And then other detox on more of a low-cost basis through peer recovery organizations with some variable outcomes and variable opinions in the addiction community. But that does exist in some parts of the Commonwealth. Ours is not an area that currently has that.
Are there HIPAA concerns / violations for a pediatrician accessing a mother's drug monitoring report in order to identify infants at risk of opiate withdrawal?
PMP guy. Yeah. Ralph?
I can't speak, but the basic law says that a when they're initiating treatment of a patient or providing another. That would probably be one of those things that requires a legal opinion.
Ralph, let's sort that out. Let's get an opinion.
Okay.
I'll add somewhat of a corollary point on that is that in terms of the moms, our OB practices, which are private practices in our community, 4 years ago, 3-4 years ago, started drug testing at every initial prenatal visit and started addressing the issue on their own and kind of brought a lot of them with our neonatologists and pediatricians were some of our earlier work in substance abuse that wasn't included in today's presentation. And they found about 15 to 18% of their moms tested positive for a drug of abuse. And like the secretary said early on, it knew no boundaries. It was all socioeconomic classes, all different educational backgrounds, and it was around 15-18% test positive at the time of their first prenatal visit. And then if they test positive, they go into an ongoing monitoring program with those practices.
If I could add there, I think that just good medical care for a new mom would include not only opiates, but other substances such as alcohol, tobacco, which we know impact fetal development.
Absolutely, and a fair number of them were testing positive for marijuana, and that's going to have some adverse effects on the child as well.
All right, we have a number of questions remaining, but I think we're going to do one last one, and then Dr. Hazel wanted to wrap this up for us. So this question is about technology, and how do you see that helping addicts? For example, there's a proliferation of applications to help addicts, and there are ankle locks used with parole officers. What is working and what is not working?
So we actually had a recent discussion with our Congresswoman Comstock regarding this. This is an area of interest for her and her staff, and I would say we're pretty early to this game in terms of trying to get a good understanding of what's working, what isn't, in terms of the use of new electronic devices and apps in this arena. We don't have any current experience of ours. We just started exploring this, and I don't know if any of the other, Secretary Hazel or anybody else from the Department of Health may have some other insights.
I can't say that I have a technology-specific response.
Okay. Secretary Hazel, I know that you had a few additional comments for the end of the presentation. You may go ahead with those now if you would like.
Well, I just wanted to thank the Substance Abuse Coalition for really terrific long-term work. This is not a problem that will be solved easily, and I'd like to thank them even more, along with VHHA, for putting this program together to teach us how to do it. Whether it was just good common sense, which is often not common, or whether it was learned, this is an example of how collective impact is working. And I believe if you look at the goals that they had set back in 2014, those will be met. And I would challenge to add one more goal, which is to disseminate this model even further. The culture change that we need to have at the communities about use of these substances is one thing. The culture change that we need to have as we address them is so important. One area of culture change that has come up several times is the integration of the recovery community, the peer community, into our programs that we've not, I think, thought about as much. The fact that substance abuse is now the leading cause of foster care means that we're bringing social work in different ways than we have before. I do think we have a good bit of work to do in terms of resourcing. And I encourage all of us to continue to work together over this next year to see if we can get additional resources put into solving this problem. Again, thanks to all for participation, and best of luck in implementing what you've learned.
Thank you very much. Thank you to all of our presenters. As Secretary Hazel just said so well, we know that you've put a lot of time and energy into everything that you've done, as well as into this presentation, and we appreciate you doing this. To our attendees, thank you for making the session a priority and for your commitment to making a difference where you are. If you have any further questions, and we know that there are still many, please feel free to reach out at any time to our team. You can visit VHHA's website at www.vhha.com. You will find our contact information there, and you can feel free to email us at any time. Everyone who registered for this session will receive the link to the recording of this session within 1 to 3 business days. Please feel free to share this recording with others who could benefit from the information. Also, I encourage you to take a look at the handout that's provided. We will be sending that with the recording. The coalition put this together, and there are a number of online resources available to you. Thank you all for everything that you do every day to better your communities. This concludes our session.